Welcome to the 7th session of the CDC's Public Health Grand Rounds. I would like to welcome those of you who are here with us in the auditorium and remind you that you can certainly watch us from here or from IPTV or in Vision Land, and you can find the information on our director's webpage. I also like to welcome a number of people who are watching us through the CDC internet webpage, and would like to say that there are a couple of new features we have added. One is that you can actually email us with your suggestions, comments, feedbacks, or anything else that you would like. Also, you can subscribe to get email alerts about these events so that you can be reminded about their time and place. Those of you who may have missed some of those events, you can certainly go to internal or external web page and found all of those archived. And here is an example of the session we had last month, and you can see that you can either watch it or you can download the PowerPoints. For this specific event today, we have a number of additional resources, references, web pages, and links that will be provided today at the web page, and our speakers may refer to those resources. Again, just want to make sure that you know these sessions are available for the continuing education credits. I do want to give credit to people who are keeping some of our activities, such as science clips, and these events aligned, and so that selected articles about the radiological and nuclear preparedness are featured in our weekly science clips. One might not say that we're having an enormous increase in the viewership, judging by the number of people in this audience. But the fact is that we have a lot of people viewing us live, and these are the numbers that actually document that we started with about 100 people with our first event. This is the slide that I showed you last time that actually documented that there's a lot more crowd outside than here in this auditorium. But I actually want to tell you that things are getting pretty hectic, and that our Congress, with their job bills and health care reform, is now competing for the attention of the health grand rounds. And as you can see, people actually have to sit on top of each other to see this. So those of you who are having comfortable seats, think of this as a commodity. I do like to welcome you see a spectacular cast of characters here, and you will enjoy hearing from them. But I do like to point out two people, and I'm going to burst the bubble with two key messages. One key message, and I'm sure the director will be thrilled to hear this, and we'll mention it again over and over, is that the state and locals is where the rubber meets the road. And so we're delighted to have Kate Uranic, Titanic Uranic. That's how she instructed me to. And she does act like a Titanic, but not sinking, going strong, who is holding the entire New York City when it comes to the radiological preparedness. That comes on the front end as our key speaker. At the end, the second message is that everything that is done for the radiological and nuclear preparedness has to be a part of the overall preparedness. And there isn't a single person at CDC who has to work in a more coordinated manner with every single program at CDC than our own Dr. Dan Sausin, who is truly a one-man band show, and he's going to close this program. So let me just remind you that there are upcoming sessions are focused on nanotechnology, chlamydia, and obesity, and I certainly hope to see you there. And as usual, I will welcome our director, Dr. Tom Frieden, to provide a few comments.
I don't know, Tanya, with those graphics, people may not want to volunteer to be in. But I really want to credit Tanya for really superb work coordinating these and turning them into exactly what we all wanted to have, which is rigorous science and cutting-edge issues in public health. Radiological safety is very complex and something that we don't think about as much as perhaps we should in public health at the federal, state, and local levels. And we can have a role, relatively unusually, in all aspects of the response. And we need to have a role if we're going to try to maximize our effectiveness. The first is in prevention. And many health departments are involved in licensing facilities which provide radiotherapy or other interventions that may actually be able to be used for malicious purposes, and ensuring that we safeguard the radiological materials that are used in those procedures is a core mission of the health system and of public health. Second, in the immediate response, there are enormous implications for public health, and simple things like how long to shelter in place and what route to take for evacuation can make the difference between life and death for hundreds of thousands of people in the event of an improvised nuclear device. And third, in the recovery period, knowing when to go back, understanding the level of risk and safety is something that is going to be a responsibility of the public health system. So best that we be ready for it now, and I'm delighted that we have this session today to contribute to that. Thank you very much.
Thank you, Dr. Frieden. Well, good morning. I'm Scott Deichman, the Associate Director for Emergency Preparedness for the National Center for Environmental Health and the Agency for Toxic Substances and Disease Registry. Today's Grand Rounds takes a somewhat different tack than previous seminars, which have discussed prevalent health threats with demonstrable health burdens. Radiological and nuclear disaster preparedness are different in that we must prepare for a public health threat that is primarily conceptual rather than current. Both real-life events and possible scenarios justify public health preparedness for radiological and nuclear events. Sources of radiation used in healthcare or other industries can be lost or misused. The criminal use of polonium-210 in London is a prominent example. Accidents in the radiation industry, such as Chernobyl or 3 Mile Island, also require a public health response. Radiological terrorism could involve the use of a radiological dispersal device, or RDD, a device using conventional explosives to disperse radioactive materials. This could expose people to radiation and would contaminate the areas where they work and live. And the most devastating consequences would result from terrorist detonation of an improvised nuclear device, or IND. The public health sector will be essential in the response to radiological incidents, whether pre- or post-event. The post-event response has 3 phases: early, intermediate, and late. The early phase occurs in the initial hours. The intermediate phase can last from hours to days, and the late phase can last for months. But at all times, before and after events, public health authorities must provide a frightened public with information on how to protect themselves. Pre-event responsibilities include identifying pre-existing radiation sources to have a baseline, conducting radiation training and exercises, and developing partnerships and coordination with others, such as state and local authorities, the Department of Homeland Security, and the Department of Energy. The early phase involves monitoring indicators that a release has occurred and identifying the likely areas of contamination. While little information might be available in the early phase, the public still needs information about how to protect themselves, as seen in this example of a screenshot from Top Off, a radiation exercise. The intermediate phase of the response has many components that resemble activities in any public health response. This broad spectrum includes identifying the sources of radiation, assessing and meeting victims' needs for decontamination and for medical care, conducting epidemiologic investigations to identify people at risk, ensuring the safety of food and water, and protecting responder health. The late phase begins when we undertake recovery and cleanup actions. The public health sector will not conduct these actions alone, but we must be part of those actions taken. These include defining re-occupancy criteria, including acceptable levels of residual radiation, and working with those who decontaminate facilities and resources. Our speakers today will cover all phases of preparedness and response, but because the intermediate phase is the most complex, they will especially focus on that aspect of the response. Dr. Urine will present a detailed review of the public health needs from the state and local perspective. Dr. Miller will discuss challenges we face and opportunities we have for being better prepared. Dr. Jones will speak about the critical role of the laboratory in detecting and identifying radiation exposure and contamination. Dr. Halpin will address the importance of protecting emergency responders. Finally, we want you to leave with the understanding of how critically important it is that radiological and nuclear preparedness and response be integrated into the overall public health all-hazard preparedness and response efforts. And Dr. Sosna will discuss that. Thank you very much. Dr. Urine?
Thank you, Dr. Deichmann. Good morning. I'm Dr. Kate Uranek. I'm the Senior Medical Coordinator for the Healthcare Emergency Preparedness Program at the New York City Department of Health and Mental Hygiene. I want to thank the CDC for inviting me to speak today on this very challenging topic. Today's public health grand rounds addresses a difficult topic for many public health emergency planners, especially when the perceived need for such planning seems low on our list of priorities. This is in part because radiation and nuclear planning is often associated with the nuclear power industry or terrorism involving the use of RDDs or improvised nuclear detonations, such as INDs, which is an unlikely scenario for most, if not all, municipalities and states. And history does prove this to be correct, in that there's been only one known use of radioactive material in a terrorist threat when an undetonated explosive RDD was discovered in a Moscow park in 1995. But this reasoning for not planning is faulty. To illustrate the need to plan for radiological incidents, I will start my presentation by describing two events that impacted New York City but could have occurred anywhere in the country. First, on Sunday afternoon, August 29, 2004, the night before the start of the Republican National Convention in New York City, the Department of Health was notified of an ensuing radiation incident at a Midtown Manhattan post office. An industrial radiography instrument being used to film reinforced concrete slabs in a ceiling malfunctioned. The radiation source failed to retract back into its protective shielding, resulting in dangerously high levels close to the source. Police and fire evacuated the building, which was mostly empty because it was Sunday, plus multiple streets were closed off. But it did take over 24 hours until the source was safely removed and protected. The actions of the health department during this time included extensive environmental surveys outside and throughout the building. We provided and assisted the police with shielding the source. We conducted press conferences. We canvassed the area with over 2,000 fact sheets for residents in nearby buildings. We did conduct dose estimates for the contractor and also for Postal Service employees. And we determined that the public's maximal risk of exposure in a worst-case scenario was less than receiving the amount of radiation in a single chest X-ray. Lessons identified in this incident are that incidents can happen at any time and any place. Communication during radiation incidents is significant even when the public is not at risk. Response requires coordination with multiple agencies, and therefore planning requires multi-agency input. A second incident, one that affected public health agencies in the United States, actually occurred in London in 2006. Alexander Litvinenko, a British citizen and former Russian KGB agent, had tea with some persons of interest in a London restaurant. 3 days of abdominal pain, nausea, and vomiting, he checked himself into a local hospital. His death, several weeks later, was determined to be caused by poisoning with the radioisotope polonium-210. The investigation revealed that polonium contamination was spread to many places in London by either the victim or his murderers. Thousands of people, including many foreign visitors, were potentially internally contaminated. In the United Kingdom, 738 people of over 8,000 persons who contacted the public health authorities met the criteria for bioassay monitoring, but only 15 of those were found to have internal contamination considered to be of potential concern for long-term health effects. Here, in the United States, citizens from 52 countries were also potentially involved. 160 of those were here in the United States. 28 of those were in New York City. In all, over 20 state and local public health agencies in the United States worked with the CDC to notify, communicate, and coordinate laboratory testing of the involved citizens. The major lesson identified in this case was that even for events that occur continents away, state and local health agencies may be involved in response and communicating concerns about health effects of radiation. And so here we go again. As Dr. Deichmann has pointed out, there are numerous roles that state and local public health agencies may have to address during a radiation incident. This list, which is just a mere sampling of responsibilities from all phases, can seem quite intimidating. Even for personnel who may be incredibly comfortable planning for a pandemic influenza or a terrorist attack utilizing smallpox, the reflexive position may be, it's not my responsibility, and it's because it's not my area of expertise. But insufficient planning or knowledge does not deobligate public health from these roles. So what is the current of the state and local capability to effectively respond to radiological or nuclear incident? The answer? It varies across state and local jurisdictions, typically due to previous experience or the perceived threat of such an incident in the region. For example, 31 states with commercial nuclear power plants are required to have detailed response plans and drills, but only for the designated zones around their power plants. Some major metropolitan areas are considered high risk for terrorism, such as Los Angeles, California, and my own New York City. And each of these localities have done extensive planning, while other regions or states have modest or limited planning. Furthermore, each state has one or more radiation control programs that house tremendous assets of radiological expertise. In 35 states, these programs are located within the Department of Health. In the other 15 states, the expertise and manpower is found elsewhere in the state government, typically in the environmental department. To ensure adequate response and planning, it is critical that state and local public health agents engage with these control programs. Beyond the limitations of capacity and capabilities, states and localities all face similar challenges, including the following. First, it's the lack of awareness of public health's extensive role and responsibilities in radiological emergencies, especially in the role of communication. This plays a significant challenge because without this awareness, planning does not take place. Even as awareness exists, lack of funding related to lack of prioritization at the national, state, and local levels is probably the greatest obstacle we all face for emergency planning for any hazard. And this is particularly evident in radiation and nuclear response planning. Thirdly, due to the lack of expertise, it's difficult for public health personnel who have little or no knowledge of radiological agents to be able to appropriately plan, drill, and respond for these incidents. And lastly, even if awareness, money, expertise exists, there's a lack of human resources to complete plans and exercises with all the other competing priorities in public health. So how do we address these challenges? Well, first, in regards to funding, the first step is that you have to increase the priority of this type of planning at the national, state, and local levels. When prioritization increases, funding typically follows. Planning for these programs is an iterative process, and even under the best of leadership, takes years to develop, train, and test plans. It is also important to be resourceful when going after funding. And here's a list of grant lines that we have used in New York City for radiologic planning. Additionally, think regionally. Funding and planning resources may be available from your surrounding municipalities to create regional detection and response plans. As an example, here's a multi-year effort we have been working on in New York City called the Radiation Detection Equipment Project. The goal was to provide detection equipment and necessary training to hospitals and non-fire department ambulances throughout New York City. The equipment is intended for the use in hospital emergency departments and EMS units, both for the detection of unknown radiation contamination on arriving patients and during a known radiation incident involving radiological contamination. This project requires the continuous, creative, and tenacious efforts of multiple grant managers. Grant lines from the Urban Area Security Initiative, DHHS, the CDC have all been utilized for this project, as you can see on this slide. And the project has resulted in the installation of 149 area radiation detectors in 57 hospitals, the distribution of over 2,000 personal dosimeters to city hospitals and EMS units, and training to approximately 500 hospital staff and 500 EMS personnel on response and the use of this equipment. This year, we will be conducting drills at 17 of the hospitals to test their ability to detect radiation contamination on an unannounced patient. As for finding expertise, this can prove easier than finding funding, but requires public health planners reaching out to agencies, organizations, or experts that they may not interact with on a regular basis. So here are some of the key partners within the federal and state sectors. And as indicated before, and most importantly, public health planners must identify and partner with their state and local radiation control programs if this has not previously been done. To find local experts who may be willing to be active as planners and or responders, or at least serve as advisors, identify and enlist personnel from your jurisdictions areas such as nuclear power plants, universities, research, and hospital radiation safety programs. Also, consider soliciting assistance from state and local chapters of professional radiological associations, such as the Health Physics Society. As it is apparent, public health cannot possibly house all the needed expertise for such planning efforts. An example of multi-agency partnering is the New York City Radiation Materials Security Audits, conducted over 4 years at most of our hospitals and academic licensees. A multi-year security audit training program was established to assist hospitals and other licensees to meet and exceed newly established radiation materials security requirements issued by the Nuclear Regulatory Commission in 2005. This audit program involved on-site visits by my department's Office of Radiological Health, the New York Police Counterterrorism Division, and Brookhaven National Labs, a part of the Department of Energy. In all, 80 licensees were visited, including 63 New York City hospitals. At these visits, which are non-regulatory and non-punitive, consultations concerning security was provided by the police and the BNL personnel, as well as training for hospital staff and increasing security. At the end of the program, a guidance document for best practices for securing radioactive materials with a security self-audit checklist was provided to all New York City licensees, as well as much more detailed inventory of radioactive materials was now available and shared with New York City responding agencies. But even states with a plethora of expertise may not have enough personnel time to create a radiological emergency response plan from scratch. Therefore, to shorten the timelines required for planning and to avoid the reinvention of the proverbial planning wheel, states and localities are encouraged to utilize and modify existing drafts of plans and protocols created by other states and municipalities already tackling these topics. As an example, I'm showing the cover of the New York City Hospital Guidance for Responding to a Contaminating Radiation Incident, a document I was intimately involved with, which is available online for other planners to utilize. This and other resource links will be available at the Grand Rounds website. And as a final note, I would encourage the audience to attend or send staff to an upcoming conference hosted by the CDC and planned for the spring of 2011, titled Bridging the Gaps, Public Health and Radiological Emergency Preparedness. I hope to see you there. Thank you, and I now turn the program over to Dr. Charles Miller.
Thank you, Dr. Urine. Good morning. I'm Charles Miller, and I'm Chief of the Radiation Studies Branch, Division of Environmental Hazards and Health Effects, National Center for Environmental Health. You have just heard that you should be concerned about events involving radiation. I'm now going to discuss exactly what you should be concerned about. I will begin by presenting a brief introduction to radiation as it relates to public health and emergency preparedness. I will discuss some examples of public health emergencies involving radiation, My main focus will be on the gaps we face and the opportunities we have as we prepare for a public health emergency involving radiation. Some atoms are unstable when they are created, either naturally or artificially. Such atoms are radioactive, meaning that they spontaneously emit radiation from their nuclei. They are called radionuclides, and they primarily emit one or more of three types of radiation as they decay to a stable atom. Alpha particles, which are composed of 2 protons and 2 neutrons. Beta particles, which are identical to electrons. And gamma rays, which are very energetic waves or photons of electromagnetic energy. The 3 major types of radiation have different abilities to penetrate matter. Alpha particles travel about an inch in air and can be stopped by a thin layer of paper or clothing, or the outer layer of skin. As a result, they are not considered an external hazard to people, but they can damage tissue if they get inside the body. Beta particles can travel from inches to many feet in air. Beta-emitting contaminants on the skin may cause skin injury, and beta particles may be harmful if they get inside the body. Gamma rays travel many feet in air and many inches in human tissue. Thick layers of concrete or lead are needed to shield against gamma radiation. And Dr. Jones will be talking in more detail about detecting these emissions. It's important to distinguish between contamination and exposure. Exposure refers to coming in contact with the radiation emitted by radioactive materials, but not necessarily the radioactive materials themselves. Contamination refers to radioactive material that has been deposited in undesired locations, such as on a person's skin or clothing. The radiation emitted by the contaminant causes radiation exposure, so the contamination must be removed to stop the exposure. One example of this difference is when a person receives an X-ray. He or she is exposed to the X radiation, but there is no contamination with any radioactive material. When radiation interacts with the human body, it gives up the energy it is carrying. This interaction can cause an atom to become an ion. If that atom is part of a molecule in a human cell, the result could be impaired cell function, damaged DNA, or cell death. The amount of energy that radiation deposits in the body is the radiation dose. It may be quantified by the unit called the sievert. The higher the dose, meaning the greater the amount of energy deposited in the body, the greater the potential for harm, because more cells are affected. At very high doses, death can follow within hours to days. At lower doses, radiation can cause mutagenic damage and the development of cancer. People on Earth are exposed to radiation every day of their life. The amount of radiation a person receives depends on many factors, including where they live, what they eat, and various other lifestyle factors. The National Council on Radiation Protection and Measurements estimates that in 2006, the average American received an annual dose of 6.2 millisieverts. Of this dose, approximately half came from natural sources of radiation, such as radon from inside the Earth and cosmic rays from outer space. Radiation received from these sources is commonly referred to as background radiation. The remainder of the dose a person receives comes from man-made sources, with medical procedures, on average, composing the largest source of these exposures. Now, people have also been exposed to radiation as a result of unintentional events. One of these occurred in September 1987 in Goiânia, Brazil. A scavenger found an abandoned radiotherapy unit in a former medical facility. He broke open the source capsule to reveal a blue powder. This powder was found to glow in the dark. It made nice-looking patterns when it was spread on parts of the body. Children and adults played with the powder and then did other things, including eating, without cleaning themselves up first. Eventually, a lady became ill and went to a public health clinic for help. There she was diagnosed with acute radiation sickness. The glowing powder was the radioactive material cesium-137. Other deliberate acts have also exposed people to radiation. For example, on August 6, 1945, a nuclear weapon was dropped in Hiroshima, Japan. Almost 5 square miles of the city were destroyed. This bomb used enriched uranium for its explosive power, and the design was not tested in advance. This was basically an improvised nuclear device, or IND. This bomb was detonated at a height above ground to minimize environmental contamination. Let's compare the impact of these two events and their implications for planning. In Goiânia, 4 people died and 249 people were contaminated as a result of this radiological dispersal, or RDD, event. But over 100,000 people had to be monitored. Current RDD emergency planning assumes similar impacts. In 1947, the Atomic Bomb Casualty Commission estimated that the Hiroshima detonation resulted in approximately 100,000 deaths and 37 physical injuries. An additional 177,000 people survived the detonation but suffered various psychosocial problems. Current IND emergency planning assumes a surface detonation scenario that will result in not only deaths and injuries comparable to Hiroshima, but also significant and dangerous contamination miles downwind. Consequently, thousands of people could require monitoring for contamination. As mentioned by Dr. Deichmann, the public health sector will be essential in the response to radiological incidents, whether pre or post-event. Let's focus on the gaps we face and opportunities we have to be better prepared. Before a radiological event occurs, we can identify pre-existing environmental radiation levels that can serve to inform future decontamination, cleanup, and recovery decisions. For example, this background radiation map of Washington, D.C. identifies several elevated radiation levels from natural sources. Also, little is known about the baseline concentrations of certain radionuclides in human urine. Public health laboratories can provide this baseline human surveillance data that can inform medical countermeasure treatment decisions. We can conduct training and realistic exercises to increase the awareness and proficiency of the public health workforce in a radiation emergency. CDC is working with a number of public health partners to help them organize a coalition of organizations dedicated to advancing the nation's ability to prepare for, respond to, and recover from radiological emergencies at the local, state, and national levels. Let's move on to the early phase response. Providing public information is challenging, but effective communication can inform the public of appropriate protective actions and help mitigate psychosocial concerns. We can use tools like plume models to estimate where the contaminated areas and safe zones may be and to identify potential evacuation routes. The estimated contamination zone can drive epidemiological investigations to help prioritize people to be tested for external or internal contamination. We can also use forecasted information to provide initial protective action guidance. For example, the model-based initial protective action recommended for an improvised nuclear device is for the public to seek shelter. Go in, stay in, tune in. However, monitoring is always preferable to modeling, and monitoring data should be used as quickly as they become available to guide decision-making. All of the intermediate phase public health response elements listed here are part of an umbrella term called population monitoring. Population monitoring requires resources in a number of disciplines, including epidemiology, laboratory sampling and analysis of biological samples, and health physics. Some state, local, and tribal public health authorities can handle events involving a small number of casualties, such as an industrial accident, but none are fully prepared to deal with a large mass casualty event. Furthermore, federal resources that would be requested to aid state and local officials in this effort are severely limited too, especially in the areas of laboratory sampling and analysis and health physics. CDC is addressing the challenges of population monitoring in a number of ways. We have developed a guidance document to help state and local emergency response and public health authorities evaluate their emergency response plans and prioritize allocation of existing resources. We are working with state and local partners to develop data collection and reporting tools specifically designed to address the epidemiology, surveillance, and registry needs of a radiological or nuclear public health emergency. We are developing guidance for using readily available handheld instruments for internal monitoring where appropriate. And we are addressing staffing needs by working with various partners to encourage radiation professionals to become volunteer members of their local Medical Reserve Corps unit. As the event moves from the intermediate phase to the late phase, additional roles for public health begin to emerge. One issue will be managing contaminated human remains, both safely and with dignity and respect. CDC has prepared both written guidance and instructional videos to help medical examiners and mortuary staff deal with this issue. Public health will play a key role in managing the cleanup and recovery of land and facilities that have been impacted by the event. Public health will need to work with a wide variety of community stakeholders in an iterative process to determine how best to recover and reuse the impacted facilities. There are many issues that must be addressed during the recovery and cleanup process, as are listed here. The temptation will be to address the last issue first. However, the answers to the previous questions will to some extent drive the answer to the last one. For example, a small wooden structure contaminated with radioactive material might be completely removed and the site returned to its natural state. That might be more difficult if multiple city blocks of a modern city are contaminated. Public health is a key stakeholder throughout this process. As we improve public health preparedness in this area, we will work with our various partners to expand our ability to provide effective and relevant technical assistance to state and local health departments. If we in the public health community continue to work together and build on the capabilities we already have, we can recover from a major terrorist event, even one involving an improvised nuclear device. I thank you. And Dr. Jones will be speaking next.
Thank you, Dr. Miller. Good morning. I'm Robert Jones, Chief of the Inorganic and Radiation Analytical Toxicology Branch in the Division of Laboratory Sciences in the National Center for Environmental Health. This slide shows how radiation exposure and contamination is assessed. Sorry. I'm going to address how radiation exposure versus contamination is assessed in people, how internal contamination can be assessed, specifically state-of-the-art radionuclide detection and bioassay technologies for internal contamination, why radionuclide testing is important, CDC's current progress on the urine radionuclide screening and quantitative bioassay methods, the current capabilities and the future goals of CDC and state health laboratory. This slide shows how radiation exposure versus contamination is assessed. With an IND, many people will be exposed to radiation from strong gamma rays and have no external or internal contamination. The primary assessments of an exposure of this type are lymphocyte depletion and chromosomal analysis. In most RDD and IND events, there will be contamination both on the body, external contamination, and in the body, internal contamination. External contamination can be assessed for all types of radiation by the use of radiation meters. Internal contamination by strong gamma emitters can be detected by whole body counters, radiation meters, and a urine bioassay. Internal contamination by most alpha and beta emitters require a urine bioassay. Shown here is a listing of radionuclides of concern from an emergency response point of view. Because all of these radionuclides can be detected by urine bioassay methods versus a limited set of radionuclides via other methods, our laboratory efforts have focused on developing rapid urine bioassays. They include both the traditional radiation counting technologies, alpha, beta, and gamma spectroscopy, and liquid scintillation counting, as well as state-of-the-art mass spectrometry analytical methods. This allows for the most efficient and rapid detection based on the type of radioactive decay. Due to the sensitivity of these urine bioassays, exposure can be evaluated, in most cases, days or weeks after an initial exposure event. The urine radionuclide screen uses a two-step process to optimize sample throughput, yet retain the sensitivity and specificity requirements. First, in step 1, we screen the urine samples for all 22 radionuclides of concern. Within 8 hours, we can test the first 100 samples to determine the types of radionuclides present in the urine. For example, a gamma versus a beta emitter. Once the radionuclide is identified, we have a throughput of 250 samples per day for alpha and beta emitters and 3,000 samples per day for gamma emitters. In step 2, we identify and quantify the radioactivity for the medical management decisions using all the technologies previously mentioned. With a throughput of 250 samples per day, our goal is to have methods to identify and quantify all 22 radionuclides of concern. We currently have methods for 7 of these. Only a spot urine sample is required to perform both steps above, and all of these methods are CLIA certified as required by U.S. law. These rapid bioassay methods are critical for defining the baseline contamination, identifying persons with post-event internal contamination for estimating radiation dose, and for directing the short and long-term medical care. They're also important for differentiating between contaminated and non-contaminated persons, thus reducing the stress on the public health system and providing psychological assurances to the unexposed. Also, providing support to the epidemiological investigations. The primary needs for an effective public health response to a national radiological or nuclear incident are to develop the analytical methods to identify and quantify the remaining 15 radionuclides of concern and increase sample throughput through automation. Presently, the state public health laboratories that analyze radionuclides in the states have no rapid analytical methods for clinical samples, according to recent surveys by the Association of Public Health Laboratories and the Conference of Radiation Control Program Directors. Consequently, they would be unable to assist in a national radiological incident with clinical sample surge capacity. Therefore, to develop this surge capacity, there's a need to establish a Laboratory Response Network Radiological, or LRNR, including 10 or more state public health laboratories. This would include training, technology transfer, and ongoing performance evaluations. In conclusion, CDC has developed screening and quantitative methods for assessing human radionuclide contaminations. We have the science-based plans for developing the remaining analytical methods. There is currently no other such capability in the nation. The next speaker, Dr. John Haplin.
Good morning. My name is John Halpin, and I'm the medical officer for the Emergency Preparedness and Response Office at the National Institute for Occupational Safety and Health. I'm going to take a few moments to talk about the health and safety of workers involved in a radiological or nuclear event and the measures that they can take to adequately prepare themselves to respond in a safe and effective manner. A radiological response has the potential to involve very large numbers of emergency responders, healthcare workers, and recovery workers, many of whom will have very little experience in radiological and nuclear response. Education and training will be crucial to ensuring their health and safety. They will need to recognize the acute health effects of high-dose radiation and understand the long-term risk of cancer, which can result from low-dose radiation. They will also need to become versed in the protective principles of time, distance, and shielding, and learn how to apply these principles in a safe and effective response strategy. Radiation safety zones, such as those illustrated here, are designed to guide the types of response activities which are reasonably permitted in each zone. In this example, work conducted in the innermost extreme caution radiation zone, shown in red, should be restricted to life-saving activities, with less urgent activities being appropriate to areas further from the epicenter of the event. Responders will also require specialized radiation monitoring equipment to mount a safe and effective response. There is no personal protective equipment specifically designed to protect responders from external radiation. They must instead rely on monitoring equipment to alert them to such exposure and gauge the appropriate time and distance they should spend around a radiation source. Personal dosimeters, such as the one shown on the left, should be capable of sounding a warning when wearers enter areas of unsafe radiation exposure and should record cumulative personal dose. Radiation detection equipment, such as the survey meter pictured here on the right, can monitor ambient levels of radioactivity, allowing responders to ascertain the safety zone in which they are operating. Such equipment must be properly calibrated and maintained to be sure that it is ready for use when needed. Radiation monitoring equipment can only be effective if used within the context of well-defined radiation exposure limits. The Occupational Safety and Health Administration has set an enforceable legal limit of 50 millisieverts per year for radiation workers. This is approximately 10 times higher than the dose that one can expect from background radiation, as was pointed out by Dr. Miller. This exposure limit will be most applicable to responders engaged in cleanup and recovery activities or on the periphery of the acute response. For those responders involved in life-saving activities in the higher radiation zones, more liberal exposure limits have been recommended. The most commonly cited is that of the Environmental Protection Agency, which allows for up to 250 millisieverts total exposure for those responders specifically engaged in life-saving activities. Personal protective equipment, or PPE, is the third crucial component of worker safety and health. While this equipment cannot protect against direct external radiation, it can serve to protect the responders from radiological contamination, which is both an internal and external hazard. The need for such equipment will vary depending on the type of radiological or nuclear response. NIOSH, as well as other organizations, have prepared guidance documents to help in the selection of appropriate PPE for radioactive environments. There are also several key planning documents available, which include sections on promoting worker safety and health. These include the Planning Guidance for Response to a Nuclear Detonation, produced by the Homeland Security Council, and Management of Terrorist Events Involving Radioactive Material, produced by the National Council on Radiation Protection and Measurements, or NCRP. In summary, I'd like to reiterate that ensuring worker safety and health during the response to a radiological or nuclear event will require specialized education, unique radiation monitoring equipment, and appropriate personal protective equipment. The challenge for public health will be to ensure that all responders have the means, access, and opportunity to acquire these three crucial components of radiological safety and health. Thank you. Our closing presentation will now be given by Dr. Dan Sossin.
Thanks, John. Home stretch. Tanya got one thing right. Working in preparedness is all about connectivity and collaboration. What she didn't get right is that Dan Sossin is not a one-man band. There's a really special workforce that we have here at CDC and I believe at the state and local levels that addresses preparedness, and we're very fortunate. So my role is to very briefly, really this is the home stretch, reflect on how federal resources directed for public health preparedness and response can be used in support of radiological and nuclear disaster preparedness. I'm particularly honored to share the stage with a team of true public health heroes who really exemplify the intellect, the ingenuity, and commitment to health security that is resident in the public health workforce. What has been done with a very small amount of resources to make a complex issue that is a frightening scenario look manageable is truly remarkable. I have 3 points, and that's not one of them. But Tanya wants to make sure you get something out of my talk, and that's why you have the event phases on the bottom. All right, the first point. While historical and more recent national interests have really focused in on infectious disease threats and the threat of biological terrorism, the fundamental principle of these resources is that they support all hazards preparedness to respond to the widest range of anticipated and unanticipated threats. This provides a permissive platform, at least, for radiological preparedness. Second, we have many partners. Public health is not the response in a disaster of this type. Rather, we are part of a response. So our efforts and our resources need to be focused on what we do best. As you have heard from our presenters, there are strengths that we have in three primary areas: laboratory and epidemiologic detection and characterization of events, providing clinical as well as self-help guidance, public guidance, and where appropriate, countermeasures for medical and population response. And third, linkage across the health system from the local to national or even international levels. Whereas there is no national health system for medical care today, the public health system does allow us to reach across federal to state to local to assure that there is an integrated health system response and integrated with the broader national response. The incident command system provides a powerful structure for us to strengthen the linkage within the health system and across these sectors. All three of these functions are heavily dependent on a robust public health workforce. A challenge highlighted in previous talks is to determine how best to prepare the workforce to respond to the widest range of health emergencies. For example, having a few experts like those on the stage who can go deep, while having an adaptable workforce that functions comfortably in an environment that is conducive to rapid assumption of scenario-specific roles. Finally, the method we use to assure that our all-hazards investments are also providing benefit to specific types of events is through the development and testing of response plans. Real-life and simulated experiences strengthen coordination, help us improve future performance, and define gaps that can be corrected. What gets measured really is what gets done. By leveraging the all-hazards public health infrastructure, focusing on the strengths that public health brings to response, and committing to the development of response plans and the testing of those plans, the resources available for public health preparedness and response will more readily flow to those gaps that are identified. In closing, I would like to thank the speakers for their efforts carrying forward the torch on this important topic. With radiological and nuclear disaster preparedness, whether we want it or not, public health plays a large role as the caretakers of the public's health. This rapid fire drill set of presentations by a diverse group of public health professionals reflects the complexity and the range of expertise needed to address Radionuclide preparedness. While we'll continue to fight for attention and resources needed to develop a deeper capacity and capability for this preparedness, the challenge of resources will be mostly addressed through our ability to collaborate. So, to the many public health professionals here and on Envision in the various formats, my challenge to you is to keep getting informed on this topic, so that you can slide into specific response roles that may be needed with less uncertainty and discomfort than you undoubtedly have today. To our partners from outside of public health who have joined in and listening to this grand rounds, my challenge to you is to be prepared and receptive to the reaching out that will need to happen from the federal, state, and local levels. The success of our response depends on our ability to bridge the diverse expertise needed around radiological issues with their application in a public health response. Thank you. I think we're ready for questions.
Thank you, Dan. As Dan said, we now have time for questions. Those in the room here, please use the two microphones on either side. We will also take questions from Envision, and those in the internet audience, unfortunately, we can't take your questions in real time, but we welcome your comments. Yes, please.
Steve Monroe.
It's okay.
Go ahead. Sorry. Steve Monroe, National Center for Emerging and Emerging and Zoonotic Infectious Diseases. We're the new center. And my question, perhaps is best answered by Dr. Jones, has to do with the low-energy radionuclide tritium, which I used a lot in the laboratory. And I know that being low energy, it's hard to detect, but as I recall, the 3 Mile Island, the major release there was tritiated gas. And what are the issues on detecting and monitoring for tritium exposures?
Tritium would normally be detected again by the urine bioassay method, primarily probably by a liquid scintillation counting method. It is on our list long term to have a method for that, but at the current moment, it's not high on our list of radionuclides of concern. But we do think that it could be measured easily in a urine bioassay method.
Dr. Frieden, please.
Just first, an observation that when we engage with our partners in law enforcement and security, we'll often find in these areas that quite appropriately their major focus is on prevention. And as the prevention agency, of course, we're very respectful of that because we'd much rather prevent a nuclear event than have to deal with the aftermath. At the same time, we want to prepare for response and aftermath from remediation and onward. One of the large challenges will be the long-term monitoring of people who may be exposed to either an RDD or an IND. And I'm wondering what thinking we've had or what models we may have to do that, either through disease registries or risk registries, or what specific goals we would have for such monitoring in terms of detection and completeness of the registry. And I don't know whether anyone on the panel or anyone in the audience would like to address that.
I think you've mentioned a couple of things that would definitely be in place. Certainly the experience that CDC and ATSDR have had with the rapid registries and the registries that have been established would serve as a good starting point to begin. And we're certainly thinking about that in terms of making sure that we interface with those with whatever epidemiological tools we develop. The other thing that we would go to, I believe, is to go to the experience of the Radiation and Research Effects Foundation, which have been following the people in Japan, their survivors of both Hiroshima and Nagasaki, basically since 1945. And they've had a lot of experience in terms of what to look for and how to look for it. And I would think that if we have to deal with that in the United States, that's one place. And there are a lot of Americans who've been involved in this process with the Japanese over the years. So there's a cohort of people out there that we could go talk to and get involved with to help us as we design that.
And ATSDR does have a program they call the Rapid Registry Response. They've basically pre-scripted questionnaires for rapid registration of victims in any disaster and would be available to support state and local health departments for using that tool. Dr. Falk, I think you have something to add to this?
Everybody's probably getting their census questionnaires, but after 3 Mile Island, which conveniently happened just at the time the census enumerators were coming off duty, a registry was created, everybody within 5 mile radius of 3 Mile Island, which has been very helpful to the state of Pennsylvania over the succeeding decades, because as questions arise about cancer clusters and other issues in the general Harrisburg area, they've been able to use that registry to very definitively respond to those questions. So I think it is important to think about how to answer long-term questions. If I might ask is it okay to ask an additional question? And this, I know there's a lot of thinking about specific radiation-related planning and population monitoring and so on. But how integrated do you think this is with, say, surge capacity planning at hospitals, integration with what might have to be work with burn units and so on? How well do we do in terms of the integrated planning if there were such a major event?
I'm going to suggest we hear that both at the local and the federal level. And Dr. Uranic, maybe you could start with the New York experience.
Well, in terms of true integration, where all the plans are dovetailed together, that hasn't quite existed, yet there is a tremendous effort at most public health, at least in the states and localities, of working on the surge capacity, and that was initially brought up because of the pandemic influenza, but a great deal of work has also been doing on the rapid sudden event surge capacity. Also, burn planning has become, and burn surge capacity has also increased, and a subset of that is always in terms of addressing the needs if there was a IND. Unfortunately, even with the burn surge capacity planning that we have right now, it would not address the needs that we would have if an IND did occur. So it is being brought in, but the true dovetailing still needs to take place. I would look for the cities that have done probably the most planning for it, LA and New York City, as examples, and take a look at what their programs have been brought up. But a lot is happening currently as we're talking.
I think at the federal level there's a couple things that I think of. One is the work that's being headed out of the Assistant Secretary's office at HHS, where they're trying to identify hospitals and around the country, for example, that could help in the capacity building. So if the state and regional areas need help, they're trying to make sure there's some national capacity there. One of the things we're doing here is working with our partners to try to encourage people to volunteer and get involved in these volunteer registries that are being set up around the country. There are volunteer registries for a number of different things related to, say, pandemic flu and the like. Now we're encouraging radiation professionals to get involved in an attempt to address these manpower issues and to help cities and locals be prepared.
I'd like to add one more thing. This is an issue that is broader than just and can be addressing other catastrophes. And for example, the Haiti experience where we brushed off the NDMS, the National Disaster Medical System, and I would really like to see that expanded and reviewed. And we found that only like 29 of our hospitals in New York were in the NDMS system. We would like to have more of them involved. And so the whole surge capacity issue, particularly for catastrophic events, really needs to be addressed on a very all-hazard scale.
And that's an opportunity for us to further collaborate with the HHS Secretary for Assistant Secretary for Preparedness and Response, which also has access to national bed tracking systems for the availability of burn beds across the country, and is building capacity to have broader identification of different categories of hospital beds. Dr. Kazi, if I can ask you to wait, let's see if we have anyone on the Envision who would like to ask a question.
At the last question.
Please, I'm sorry.
I think it's important that we recognize that a nuclear detonation, truly catastrophic events, we're not prepared to fully respond to in a sort of business as usual way. There's no question that we will be figuring it out as we go and bringing what we can to the table. But that speaks to the broader importance of this all hazards approach, incrementally increasing that surge capacity, all of these various tools that have been talked about. And having that adaptable workforce. And it speaks in this particular instance to the really challenging aspect of teaching people who don't really think about radiological issues, about what the minimum is they need to know. I think the worker safety issues are really critical so that people will be more willing and more able to focus on what needs to happen and the adaptation that needs to happen during a response because they're comfortable knowing that they've got appropriate protective gear, that people have thought this through, and that they can focus on their job.
Do we have any questions from the Envision audience? We see at least one site. Did you have any questions? While we're waiting, then, Dr. Kazi.
Ziad Kazi from the Radiation Studies branch. I'm a medical toxicologist and an emergency physician, so I actually work at the Radiation Studies branch. At the same time, I'm an educator regionally in some of the states around here. And what I want to suggest to the local health departments is to rely on their medical toxicologists and the poison centers. Over the past 6-7 years, there has been a national effort to train medical toxicologists as subject matter experts. And these people are available and local and can assist. And recently in Denver, in one incident, a local toxicologist was the one who actually chelated the patient with DTPA when the patient was contaminated. The second thing I want to ask to Dr. Halpin is about the PPE that you mentioned, the airway, the PAPR, the pressured air respirator. That message for the first responders is different than the message that sometimes we send out using N95 respirators. Is there a plan to maybe get one message out there for the first responders when they actually seek a respiratory protection?
Well, what I might not have indicated in the talk is that the appropriate respiratory protection in particular is going to depend on the type of radiological or nuclear event that has occurred. So the appropriate education and training is going to be necessary, and referencing some of the guidance that NIOSH has to determine what exactly is the appropriate equipment for the type of response that you're involved in at the time. But I do think it is important that that message is clear and it's consistent among different organizations. You might be referring to some degree to some of the challenge we had with pandemic flu and deciding on the appropriate respiratory protection in that case. And we'd want to make sure that a similar type of messaging issue doesn't occur in this type of response. But certainly it's not a cut and dried answer for that you could say for any response. You really have to tailor it to the type of response you're having. And there can be some events, in fact, where respiratory protection is not really going to be a very large issue.
We have time for one last question. Yes, Dr. Keith.
I'm Sam Keith, ATSDR. I think I'd like to address this primarily to Dr. Sosin. We're working on improving preparedness. And at the same time, if we look back historically at some of the events that have happened dealing with radiation and other situations, there seems to be a compelling effort on the part of Americans to pull together when there's a catastrophic event. Following 3 Mile Island, the Navy sent loads of people up there and equipment from the various nuclear-capable shipyards to respond. Following the World Trade Center collapse, there were pictures of iron workers walking on the sites to help pull steel off. And when the World Trade Centers collapsed, I tried to pull together an effort to pull comparison values of exposure and health impact to help in the response. And I contacted ACGIH, and they sell their values for exposure limitation at that time I think $15 a piece. And after contacting them, they just voluntarily shipped information down and asked what more they can do. And I said, well, we don't have a contract. They said, you don't understand, we're all Americans. What I would ask of you, Dr. Sosin, and the panel is, how well are we prepared to accept the volunteerism that would come forward following an IND event or an RDD event? People wanting to help, how can we work to integrate these volunteers more effectively? I know Armin and Sari is working very closely with getting health physicists involved in Serve Georgia. But I think there are opportunities out there that we will recognize once an event occurs, and being prepared to deal with that. And Catherine, you have dealt with New York State. You know, how are you able to integrate the volunteerism, and could you have done it more effectively if there had been planning for that?
Well, certainly in New York during 9/11. We didn't have in place at the time. I wasn't working for the Department of Health, so I'm doing this by what I know of the history. They didn't have in place the positions to actually do that volunteer management, and that does take a lot of the responders' time. Since then, though, there has been a considerable effort used to address within the city planning of how to manage volunteerism and also the receiving of supplies, which often comes unasked for. But we also, like other states, have now started looking at actively recruiting health physicists to our Medical Reserve Corps, where they will be incorporated into the system, trained, and be a resource that we can tap on. So it's greatly improved since 9/11. But part of it is that you actually have to assign staff to be responsible for that position, and it has to be one of the planning elements in all of your plans.
Dan, once again, you get a brief last word.
Okay. So what Dr. Uranic mentioned at the New York City level is what you see at the national level, with probably a lot more acronyms to those groups. You have personnel volunteerism and you have material issues. We've come a lot farther in terms of pre-registering personnel and addressing expertise required and how we track and monitor, license, all those kinds of things. There's still work to be done. Material, there are processes, particularly when there are licensed products or and agencies that have regulatory authority over them, but have in place understandings and staff ready to step up quickly and address those kinds of volunteer needs. The third piece of volunteerism is managing the unwanted volunteerism, which in a radiological event will be a mixed issue, people running the other way and people running in unaware of what they're exposing themselves to, and complicating the management of a response. In this kind of event, you'd see law enforcement quickly, cordoning off areas, trying to maintain perimeter security, all those kinds of issues. But there will be challenges in managing the immediate response and volunteerism and the desire to do something helpful.
I want to thank everybody for either attending in person or listening and watching us via all mechanisms and technological advancements. But I also want to give a round of applause to our colleagues, not only for what they have done to put together this presentation so we can all be better educated, but primarily for what they do every day so that we're better prepared. Thank you, and see you in 4 weeks.